there! Thanks for listening to Let's Talk Withdrawal, a weekly discussion on antidepressants and the issues surrounding them.
Hello, this is James, and welcome to Let's Talk Withdrawal, a weekly podcast discussing antidepressants and mental health. This week I have something a little different for you. As some of you know, I've been running a petition for some time to raise awareness of something called Tapering Kits. Very simply, Tapering Kits are tablets in decreasing dosages that would help users who wanted to withdraw from their psychiatric drugs to do so safely and in a controlled way. Recently, I was contacted by Doctor Peter Groot from the University of Maastricht in the Netherlands. Dr. Groot and his colleagues in the Cinderella Therapeutics Foundation have invested considerable time in researching and creating exactly what my petition refers to. They have created Tapering Strips, which are a method by which users of many classes of psychiatric drugs can safely withdraw. Dr. Groot and his colleagues have successfully helped over 2,000 Dutch patients to withdraw from their medications using Tapering Strips. Needless to say, I was very excited to hear that this solution had been created and was actually helping and supporting users of antidepressant drugs. Dr. Groot kindly took time out of his busy schedule to talk to me about his own experiences with antidepressants, how he approached creating Tapering Strips, and some of the difficulties encountered along the way. Dr. Groot, thank you so much for talking with me today. To begin with, I just wanted to ask you about your own background and what led you to be interested in helping people taking psychiatric drugs.
I have had experience with depression in several ways. 40 years ago, my father ended his own life. And, he was never officially diagnosed with depression, and I don't know if it was it was more mood swings over time. So for many months he could be okay, and then there were periods he was not okay. And a number of years ago, in 2003 or 2004, I got a very severe depression. And this was not my first time with depression, but it was the first time that I considered taking antidepressants. So I went to a psychiatrist and I said, well, can you tell me what I might have, which kind of diagnosis I have? And the second thing is, do you think that antidepressants could help me? And this was a question I've been thinking about over time, several times. There you have all these problems with the stigma involved in antidepressants. Do I change because of them? Do I really need them? And if I use them, does it mean that I'm a failure? That sort of things. And when things were not going well, I have considered going to a doctor. And as soon as I felt fine, I thought, no way. But in the end, I started using antidepressants, and I'm a chemist. My background is that I'm a chemist, but I was trained more in the field of molecular biology, and for many years I've done genetic research, DNA research. So I know how to read science papers. I wrote a number of them myself. And of course, when I was trying to answer this question, I have been looking up things about antidepressants, how they work and that sort of things. And finally, I decided to start using antidepressants. And I must say the experience with the psychiatrist I had was very, very good, because what he said to me when I asked him this question, first of all, about my diagnosis. He did not say you have this diagnosis or that. He said something else, and his diagnosis was based on a classical clinical interview. But what he said was, you might belong in this group. And that was the group of dysthymia. I don't know if you're familiar with that.
It's a term I have come across, but it's not widely used.
No, it's a very difficult sort of diagnosis. You're diagnosed with dysthymia if you don't feel very well, sort of being depressed. It's sometimes described as a mild depression. And you must have that for at least 2 years. And the minimum amount of time you must not have it is about, 3 months. It's completely impossible diagnosis, because with hindsight you can never tell how many times you've been depressed or felt less well, that sort of thing. It's completely crazy.
It doesn't sound that objective, does it?
Well, it's like with depression, you have so many variables that people who have completely different things can all be diagnosed with depression. and we do it as if it is the same thing, while in fact it is not. But anyhow, that's what he said, and I found this very reassuring. He did not say, you have this might be the case. And in fact, up until this day, I don't really quite know if I have a certain diagnosis, what the diagnosis that would be. I would say it's something like susceptibility of becoming depressed or being sensitive to mood swings. Anyway, that's not so important, because the important thing is what you do with it, how you live with it. About antidepressants, he said, well, they might help, but they don't help everybody. You might also take psychotherapy, but in your case, I think you're already trying to think in schemes and so on. And he said, if you start taking antidepressants, I have a long list of them, and I cannot predict which one will be the best for you. And I still find this an excellent answer, because basically that's a question we don't have an answer on. It depends, or it can differ between persons. For one person, one medicine can be excellent and the other not, and for another patient, it's completely different. I said, how should I choose? And I ended up with the drug he had a slight preference for, although he was clear that the evidence for that was not very large, and it was venlafaxine. You're probably familiar with that.
Yes, I am. It's commonly prescribed in the UK too.
So I started using that, and for a number of years I had the feeling that I was improving on that. The problem is, of course, being a scientist, I wanted a sort of definite proof that they worked for me, because I thought, I know that only part of the people who take this drug will benefit from it. And if I'm not one of those, then I will take these medicines perhaps for years without knowing. So what I started to do was measuring my own mood in a very primitive way. Just giving my mood every day, at the end of the day, a figure, a number between 1 and 10, and I had come up with some criteria for myself. And I did this for, I think, 4 or 5 years, which actually helped me, because it gave me a story of what I might have. Not a diagnosis, but something I could do something with it. But the basic question I had, do these antidepressants help for me, I could not answer. Because when I started taking antidepressants, I was also doing other things. I was trying to run, even if I didn't want to go. I went to tennis lessons, that sort of things, because I knew this is better than staying at home. So if you improve, then is it because of the antidepressant? Is it because of the other things? I didn't know. I thought they helped me.
And Peter, when you started taking venlafaxine, did you experience much by way of adverse effects, or was that not really an issue for you?
No, not too much. Of course, when you start, you feel something, and especially the sexual effect, but this sort of waned after a while, and I was prepared for those effects. But other than that, what I can tell is for the side effects, that's a matter of benefits and harms, which I have made. I have come to the conclusion that benefits for me are much larger than the harms, so I still take these drugs. Anyway, because I wrote this paper in Dutch, I came into contact with the group in Maastricht, where I am one of the members now, and I met Jim van Os, and he told me you should write this up in a scientific journal, which I did. And in the meanwhile, I had come to know a lot more about antidepressants, and especially about the problems people have if they want to stop using them. And one of my own experiences is that if I forget one capsule of venlafaxine, then the next day I experience problems. But it took me more than a year to find out that these problems were caused by forgetting this one dose of my drugs. Because what I was thinking when I came out of bed, like I don't feel so very well, I didn't really have a headache, but I didn't feel very nice, and I thought, am I getting the flu or something? And then the next day it was gone, and then I thought, well, sometimes you have these bad days. And I don't forget, do not often forget to take a pill, which makes it so hard to find out, is it a pill or something else? So at some moment I thought, might it be because I forgot a capsule? But then I started thinking, did I forget it, or was it the day before yesterday? So it took me more than a year to find out that it is really the case that if I forget one tablet or one capsule of venlafaxine, and the next day I experience these withdrawal effects. Yeah. They come very quickly. And in the leaflet, the package leaflet, there's almost nothing about it. It is as if they don't exist. And then I started looking into things further. And in 2010, I met somebody who said there should be guidelines about tapering of antidepressants. And together we wrote a report in Dutch, fortunately for you, in which we made a sort of inventory of all the problems, you know so well from your own experience, for people who want to taper these drugs. And I also wrote down this idea for the tapering strips or the tapering kits you had your petition on. And I was proud of myself because I thought this is a very good idea and everybody will embrace this and will use this. This was not so. Because shortly after I was phoned by an emeritus professor, he's dead by now unfortunately, and he said, we have a foundation and we are trying to do what you proposed, these tapering strips or the tapering kits you want to make. And I was surprised by that. And he said, this idea of yours was in a Dutch newspaper in 2004. It was actually written down, and later on I found out that in the British Medical Journal, the same idea under another name was also published in a short letter. And if you think about it, then in fact this whole idea for tapering strips or tapering kits or however you call them is being solved, at least people try to solve it, by people who do this at home. Breaking pills, scraping off pills, or whatever you can think of, counting little things that are in a capsule and then putting them back each day a little bit less. So it's such an unbelievably straightforward idea that it's a shame that the pharmaceutical industry, who know of these problems and could have solved this many years ago, have never done this.
I agree. This idea is something that we're used to with people who are trying to stop alcohol or nicotine. We wouldn't expect them to stop suddenly. But the medical profession doesn't seem to think the same should be true of powerful psychiatric drugs.
No. One of the pictures I show these days to people is a picture with 4 people who are very different in size, in length, in weight, and also in sex. And then I say, if they go to a doctor and they are all depressed, and the doctor does everything right, and he uses the manual of the Dutch Foundation of Doctors, or how is it called, then he will end up treating these people, all of these people, the same way. So he will start giving them the same recommended dose. If I go with 2 different dogs which differ considerably in size to my vet, and they have something similar, then I'm sure that the vet will give the smaller dog less drugs than the big one. And if you think about it, this is completely insane, but this is the normal way of prescribing pills in psychiatry. It is as if the size we have, the weight we have, our sex, doesn't make a difference, but it does. And it's even weirder if you consider what we are doing when we are prescribing pills. Then we have a dose of 10 milligrams, of 20 milligrams, and of 50 milligrams. But suppose that your optimal dose is 33 milligrams, then you will get 50 or perhaps even 100. While if we buy shoes or we wear glasses, then you wouldn't accept that you would need size 45 if you have actually size 42, because 42 is not available.
That's a very good point, Peter. There really isn't any account taken of different physiologies or different sensitivities to these drugs. It's take this dose, many people are rapidly increased to the maximum dose with not that much understanding of the overall effects on the body.
Yeah, and the situation is of course complex, because a small person with low weight can actually need a higher dose than a large person, because he's wearing different enzymes or has a different kidney function or whatever. So basically what the message is that if you want to prescribe drugs, psychiatric drugs, we should also try to determine how much does somebody need. And of course, good doctors try to do this, but in our current practice, it is very difficult to do this, because what you have to decide on is actually how the patient, him or herself, is feeling when taking these drugs. And instead we use lists, questionnaires, which the value is often not so good. We have a diagnostic system which is very crude. So there is a lot of things that could be improved on. But in the end, when you look very good at the problem, the biggest problem is the problem you are trying to tackle and we are trying to tackle. That is the lack of these different doses we need for that. We don't have the instruments. And there you get very strange things we are experiencing now. That is the regulations. If a dose of 20 milligram is a regulated dose, for which files have been filled in, payments have been made, then pharmaceutical company is allowed to sell them. If you say, I've got a dose of 19 milligrams, they say, oh no, that's not registered. You have to prove that it actually works. Or if it's 21 milligrams, so we can use, like with paroxetine, you have 5, you have 10, but if you need 8 or 7 or 6, then it's a problem if you want even to provide those doses. I mean, we do it in the Netherlands because it's under the heading of magistral, I think that's a term in English too, preparation, which a pharmacist can do, but that's intended for only a few patients, while we have used this route to make it available for all patients. And that's one of the struggles we are fighting with our insurance companies, because they say, oh yeah, but it's more expensive to help somebody to get rid of the medicine than to pay for the medicines themselves, because the medicines themselves are actually extremely cheap these days, which creates a fascinating problem, and that is that helping people to have to use a medicine better, for instance by finding the right dose, is much more expensive than simply paying for giving everybody a high dose.
It's so sad, isn't it? Because there's no impetus for the pharmaceutical manufacturers to get on board with this, because keeping people on the drugs long term guarantees future income. The regulator doesn't seem that interested either, because it's more work for them, and the medical profession generally doesn't seem to view withdrawal issues as the problem that we know it is. So there's quite a lot stacked against anyone who wants to promote a solution to this problem, isn't there?
Yeah, well, I think, at least I hope that we are changing this, at least in the Netherlands. That's why most of my pieces are still in Dutch, because if we can overcome these hurdles in the Netherlands, it will be much easier to do this also in other countries. I want to make a few remarks. First of all, as far as I'm concerned, the pharmaceutical companies are not involved anymore. All these drugs are out of patent, and they're basically not interested. Most of psychiatric medications are now generic things, and they don't earn much money in it. They have sort of retracted from developing new ones, so we will be stuck with the old ones for a very long time, I guess. And the problem we are facing in the Netherlands is actually our insurance companies, because they say if somebody uses venlafaxine, to give an example, then to give him a dose for 70, then that costs something like €70 a year. But if this person wants to stop using venlafaxine in 3 months, and the strips for venlafaxine are the most expensive ones we have, they're about €150 per month, then you get an amount of money of €500, and then the insurance company says, yeah, well, €500, that's much more than the 70 we pay for a year, so we rather pay 5 years of drug use than helping people to stop in a responsible way.
That's so short-sighted, isn't it? Because they are ignoring the potential long-term harm of people staying on these medications for many years.
Of course, and they also neglect the fact that if people want to stop and they get sick because of side effects, then it can make them stop working, it will affect their social contacts, and in extreme cases, people can get violent or commit suicide. I mean, costs of that, in my view, are immensely much higher. But it's like this is not the budget of the insurance companies. So they sort of behave like the cigarette industry. Thus far, we have had a lot of resistance. But on the other hand, they are being so stupid in the arguments they use that by now there's more and more attention here. In Parliament, one of our political parties has asked questions about this, which we are very happy about, because now our Ministry of Health will be forced to give answers. But we are making progress. We have had a meeting some time ago with representatives of insurance companies, representatives of patients' federation, representatives of medical associations. So it's really becoming an issue. And what's most important, by now there is approaching or already over more than 2,000 people who have used these strips. We know quite a lot also about how they worked. So more people can stop with them. They experience less side effects. They are very satisfied about it. It does not mean that everybody who uses them is able to stop antidepressants. That's also not what you expect. But people often have the question, are the antidepressants I use still useful? And then I come back to my own story. A number of years ago, I proposed to the University of Maastricht to do something with the apparatus they had, the so-called PsyMate, in which you can monitor your own mood, and combine it in research with the tapering of medicines. And this ended up in an experiment which I partly designed myself, and in which I was the only participant, and in a number of months I tapered my medicine, not using tapering strip, that was not there, but using the systematics of that. So gradually reducing the dose in a period of, I think, 8 or 12 weeks, I don't know precisely. And the tapering went fine. So when I reached the dose of 0, I thought, no, I'm okay. And now I hope I can do without. But after a few weeks, I started having problems again. I was getting more irritated, slept less was worrying more, that sort of things. And it didn't go away. So after 4 months, I decided to go back on drugs. And I also decided to go back on venlafaxine because I thought it had worked for me okay. And the interesting thing is that I had always been using for 8.5 years, 150 milligrams per day. And when you start again, you have a week of 37.5, and then you go to 75. And when I was at 75, I felt much better, and I thought, well, I'll wait a while before I go to the 150 again. But I never went back to 150, which raises the interesting question. If for 8.5 years I have been using 2 times as much as I needed, which I don't know, or if I needed it at the beginning and later on it was possible to reduce. And I think this is a general phenomenon because we also know from people who informed us about it. Some of them say, well, I still use antidepressants, but the dose I'm using now is much lower than I used before. So the antidepressants help them, but they have to use less drugs to have the same effect, and using less drugs is less side effects.
That's really important, isn't it? Because the principle should be the lowest dosage of medication that gives you the benefit you need, but that minimizes the potential for harm.
Yeah, that's why what I show in one of my slides, the optimal dose is the high enough to have the effect you want, and as low as possible to prevent any possible side effects. Because in the end, it's always a balance. And that's why the tapering strips are not to get everybody off antidepressants, but to get the right people use them. And if you don't use them, you should have the possibility to be able to stop with them without having these side effects. And that's basically what you can do with these tapering strips.
And Peter, for people listening who may not be familiar, could you tell us a little bit more about tapering strips and how you went about creating them? How did you make the concept a reality, having written about it previously?
Well, that was very interesting because when I came into contact with this foundation, Cinderella, I had the idea of a tapering strip as a sort of anti-conception strip. You know, these with these pills, Monday, Tuesday, Thursday, and so on.
Yeah.
And I thought you have to make, say, like 28 or 30 or 40 different dosages, and then people can take every day a pill with a little bit less venlafaxine in it, or paroxetine. But making this would be very, very expensive because you need all these different doses, you have logistic problems. And then we had to find, and this was the basic idea, it might be otherwise. And then we came into contact with a pharmacist who is actually making the strips, the Rainbow Pharmacy in English. And the pharmacist said, no, you should not do it like that. You should use the system we know for the coins in our wallet. If you want to give somebody 35 cents, you give a coin of 20, a coin of 10, and a coin of 5. So with a few denominations, you can make every amount of money you want. And that's basically what we do with the tapering strip. So when he told me that, I thought this is a good idea. But then I said, how are people supposed to do this? And he said, well, there's a solution for that also. And that's called a Baxter strip, which is, I think, also familiar in the UK, which is just a way to package drugs, and it's often used in institutions, for instance, for old people who use many drugs, and then on each packet is written a time and the drugs that should be taken at that time. So the person only has to open the sacket, take the pills that are in there. And basically that's what we are doing with the antidepressants. So people get a strip and we've just chosen practically for a period of 28 days. And each sacket is numbered, and they start at day 28 with the dose they take today. And on day 27 the dose is a little bit lower, and on day 26 it's still a little bit lower. And so you can reduce the dose in 28 days from one dose, say 150 milligram, if you talk about venlafaxine, to say 75. And then you can take a second strip and go from 75 to 37.5. So we have a sort of, modular system, which gives doctors and patients the possibility to choose together for the speed they think is optimal for them. Because that's another problem. A doctor cannot predict reliably for a patient how fast a patient should taper a certain medicine. There's no possibility for a doctor to see if there's a patient on the opposite side of the desk. You should do it in 1 month and you should do it in 3 months. There's just no way to do that. It's different for every patient. 1 month may be fine for one patient, and another patient may need 3 or 4 or 5 months. We basically don't know that, even though guidelines like to suggest that this is the optimal way, but precisely because guidelines prescribe this, so many doctors and patients are confused, because in practice they say, well, the doctor said I had to do it with this speed, but I feel ill after a week. But it's very different from patient to patient. So our solution is to use what we call shared decision making. If the doctor doesn't know, if the patient doesn't know, what we can do together is point out which possibilities there are, which risks there are, which benefits, and then in the end it should be the patient who chooses to taper in, for instance, 1 month or 2 months or 3 months, and you can say something depending on the drug. And for some people it may be very important to get rid of the drug as fast as possible, and they are willing to experience a lot of side effects. And some people can actually do that. And other people say, I've had such bad experience in the past, I don't mind if it takes 3 or 4 months. But if that helps me to get rid without these things, then it's okay with me. And if you do this correctly, and if the doctor and the patient make appointments together, this is the way for the doctor. I will monitor you. Either you call me when you have problems, or we schedule a number of visits. Then if it goes too fast, we are able to adapt the tapering process. So we are moving away from the current model, which is basically that the doctor prescribes what the patient should do, and that would be the way, to a model where tapering is a process which the doctor does together with the patient, because we never know precisely what will happen. And the tapering strip allows us to do that, because It's not like the doctor says, I don't know. The doctor says, okay, some things I don't know, some things I can tell you, but we have a number of solutions which we together can deal with, which gives us a handle to come to the best outcome. But we are dealing with antidepressants with a number of fundamental uncertainties, which I think for the coming period of time we will not resolve so quickly.
Well, Peter, I think the concept of tapering strips is an excellent one, and I'm so pleased to know that this work is going on. I'm thrilled to hear that you have helped so many people either to withdraw completely or to reduce to a minimally effective dose. What I like is that it puts control back in the patient's hands, doesn't it? So the doctor and patient together can decide to reduce slowly using this method, and the patient is much less likely to suffer the effects of withdrawal than if they try to cut tablets or quit cold turkey. That helps the patient and the doctor, doesn't it?
Yeah, and what I think is important, and that's what I always stress, is that I think it also makes life for a doctor much easier, because doctors now have sort of an impossible task. The patient comes to them and says, how should I do it? But basically the doctor has problems to know what the right way is, because nobody really knows for a specific patient what should be done. We have some averages, but for a lot of patients, these averages don't work. So for a doctor, it's much easier to be honest now and say, well, okay, this is what I do, this is what I don't know, but together we are able to find a good solution. And we can also discuss what the end result will be. If you taper safely, the outcome may be, hopefully, that you can go on without drugs, but there's always a possibility that you will still need the drugs, perhaps at a lower dose. But this is what we have to find out. So in the end, you have to learn something from what you do. It's like a more experimental and pragmatic approach, which I think is beneficial for all parties involved.
It is. And Peter, what's next for you in terms of developing tapering strips?
Well, what's next for me is first to work out all the questionnaires I have and to try to get a publication out of that as fast as possible. But this will take a few months still, because that's quite a lot of work. Secondly, we like to set up research in the Netherlands in which we want to do what we call N-is-1 experiments, like the one that I did, in which we like to ask people who use the tapering strips to combine the use of those strips with this apparatus I've been using, in which they can monitor their own mood. So by answering a number of questions a number of times per day. And the important thing of that is that you get information of what happens during tapering. So you get an idea of mood swings, changes, side effects or whatever in the course of time, which is completely different from what is happening now, where you go to a doctor and the doctor asks you how were the last 2 weeks for you, which is a very difficult question because it depends very much on what happens to the person involved in the last 2 hours, for instance. It's a completely different thing, which will learn us much more about the variability that exists between patients if we can do a lot of them. And finally, one very other important thing is that we have to make sure that these strips are reimbursed in the Netherlands. And that's basically the struggle we are fighting now. So from doing sort of scientific or developmental work, I'm currently being more like a sort of activist, writing letters, having to deal with legal stuff, which I don't want to be involved in, but I have to, because our insurance companies and some official parties in the Netherlands are doing very difficult about these strips, and they are always coming back to the fact that they are more expensive than the drugs themselves, and forgetting that the drugs themselves are so cheap that in our society it's much easier for almost everything. The easiest solution is always to give people pills, because that doesn't cost money. While paying for instance, a psychologist or a caretaker in an institution is much more expensive. You can calm people by giving them pills, but is that a good solution?
It's very short-sighted, isn't it?
Yeah, it's a cheap solution, but these things are important, so that's what we're trying to convince people of.
The politics of this are deeply frustrating, aren't they? Because this is an excellent solution to a widespread problem that would help patients, would help doctors, and have many direct and indirect benefits. But the politics stop us helping the people that need help.
That's right. You're completely correct. That's why we go on, and that's why I was also thrilled when I saw the announcement of your petition. Because when I saw it, I thought, well, these are the things that I wrote down so many years ago and that others have wrote down for me, showing again how obvious the idea is, but also how difficult it is to put it into practice. And that leads me to a question. Have you made any progress with your initiative?
Well, certainly, Peter, nothing like the progress that you have made. At the moment, the petition is very much at the awareness-raising stage because in the UK, doctors are quite difficult to convince that people have any problem stopping these drugs.
Perhaps I can say something which I hope will give you some strength for the future, because what happened when we made the tapering strips available, that it were, I think, mostly the patients in the beginning who went to the doctor with the prescription that was to be found on on the website. They went to the doctor and they said, "Hey doctor, here, this solution is present and I would like to use that." And many doctors did. And a lot of doctors became convinced that there was a problem because there is now a solution that really works. The problems become much more obvious because there never was a solution. Everybody has taken it for granted and we are sort of doing as if there is no problems. But in a lot of cases, doctors don't hear from their patients what the problems are. And now there is a solution. The difference between tapering well and not tapering well become more obvious. And what we see in the Netherlands, that more and more doctors are now the ones who prescribe them and who tell the patients that they exist. Both still happen, but that leads to a change. So the attention also you pay, the awareness you're talking about, will definitely help because these problems are real.
They are, and medical professionals shouldn't be surprised that if you take a substance which exerts an effect on the body, particularly on the brain, then to be without that substance after a period of use, there's quite obviously going to be difficulties making that transition. But it's getting doctors to recognise that those withdrawal effects can be really quite pronounced for some. Not all, as you say, but for sensitive individuals, they can have many weeks or months of extremely difficult times, and they may confuse that difficulty with a recurrence of the depression or anxiety when it's actually the body readjusting to its new state.
Well, I think that the last thing you mentioned is one of the big problems, because everybody complains that we use too much antidepressants, that they are prescribed to too many people. But what we see is that it's easy to start with, and because people can't stop, have failed stop attempts, they continue using them, also because of this confusion between withdrawal symptoms and recurrence of depression, because it's not only the doctors who are confused, but it's also patients themselves who think like, oh, I'm getting depressed again, while in fact it's withdrawal symptoms. And when the withdrawal symptoms disappear, they say, oh, I need this drug. But you really don't know if you can't stop without these physical withdrawal symptoms, and that simply takes time.
It does. Writing a prescription is easy and doctors' time is severely limited, but people do need support both at the initiation but also at the cessation of drug therapy too. In the UK, there seems to be much more willingness to leave patients on these drugs for an extended time, maybe even for life, and I'm not convinced that that's good for the majority of people.
Oh, I totally agree, but I also think that what I see in the Netherlands sometimes, that it's very easy for people to point to a doctor as the guilty part, but just as you were saying, it's difficult for the doctors also. That's why I think that this practical solution can make such a large difference, because as long as you don't have a solution for a problem, then it's difficult for everybody to deal with something. Now we can tell to a doctor, yes, but listen, there is a solution. Why don't you apply it? And I think most doctors are sensitive to that, especially the ones who experience. And there was one psychiatrist already in the beginning who wrote me a fantastic email, very short. And he said, thanks to your tapering strips, I've made 3 people come off paroxetine without any difficulties. And what I read in that was like, it was difficult in the beginning, and now without, by simply prescribing these strips, they can do it. So this man is convinced of the use of that because he sees that it can be done.
That practical help to get people to where they want to be is so valuable.
It was just lacking. That's why your tapering kit makes all sort of sense, what you proposed. But it's the same proposal so many people before us. It was not my idea, it was the idea of many people. It's difficult to point out who was the first one. Every patient who tries to taper his own drug is essentially pursuing what you propose.
Yeah, and rather like you, Peter, when I had the idea for the petition, I thought, this is such an obvious solution. I'd be staggered if it hadn't happened in some way in some part of the world. And I'm thrilled to hear that working in partnership with the Cinderella Foundation, you've gone ahead and done it and actually helped people to withdraw safely.
And it's not only, by the way, limited to antidepressants, because we now have a number of these strips for antipsychotics, and the number is still expanding. Because for antipsychotics, it's often not so much a complete stopping for people, but we know that many people who use antipsychotics use dosages which are probably higher than necessary. And the side effects of antipsychotics, in my view, are often more severe than from antidepressants. So there are initiatives in the Netherlands to try if we can find good ways to help people to reduce the dose of their antipsychotics slowly. And we have also developed tapering strips for benzodiazepines, where the problem is also there. And in all these cases, I think that if you taper slowly enough, let me put it differently. I think that in principle it should be able to come off a drug without suffering from withdrawal symptoms if you do it slowly enough. The problem is that we don't know for a given person and a given drug what the speed then should be. Should it be a week, months or years? And it might be possible that for one patient a week is enough. For another patient it might be better if it was 3 months, and perhaps for somebody else it might be better if it's 2 years. And basically these are unanswered questions which we have to deal with.
But presumably, Peter, in helping the people that you have so far, you're also getting hard data on people's experiences of the time taken to use tapering strips to come off. And that's not something we've had before, is it?
No, precisely. And that's also one of the strange problems, because all the time we get questions and they say there is no evidence. And then my answer is yes, of course there is no evidence, because we've just had these strips. But what we do know is that tapering gradually, and basically you can find this back in every guideline you look at. Every guideline says you have to taper gradually. But there's no guideline who specifically states this is the right time for this drug. Because differences between different guidelines are extremely large, and in many guidelines you find, or publications, you always find these sentences, yes, but there is little evidence for this, there's little evidence for that. And if you put all this together, then basically the evidence based for the current way we taper off medicine is non-existing. And the fact that it's non-existing is always ignored. The only thing they say is, but you have no evidence. And then we say, yes, we have a lot of evidence. We know that tapering gradually is better than stopping at once, especially for drugs like paroxetine or venlafaxine, without any doubt. But still they say, but there's no evidence, there's no research being done. And that's the strange thing. And basically that's also used as a sort of an excuse. So what they are basically saying, you first should do this research, it might take you a few years. And during all this time, you're not allowed to prescribe people these tapering strips, because there's no evidence yet. Yeah, but the strange thing, they forget that our current practice, because they basically defend our current practice as if that is a proven practice. And this is not the case, completely not. Any question you have, if you have a specific question and you are looking for good answers, then in most cases you will find that they are not available in the literature. There's a lot of literature also on tapering, but if you put it all together, there's little you can make out of it. The only thing you can make out of it is that it's more sensible to taper gradually, insofar that if it has been investigated that slower tapering probably reduces the risk of recurrence. There's no evidence that points the other way around. But for the most part, we have a lot of big question marks. Because the way we did research in clinical trial was always about averages, but nobody is average.
That's true, and Peter, I'm really pleased that you've not been stopped completely by the politics and legalities. You've achieved a great deal in a very short time. I don't really understand what the lawyers think they're stopping, but it's clearly not about safety, is it?
No, but I don't know if they understand. That's why the approach that I was able to take, thanks to this foundation, that is to just start and provide it to people, in the end will be the fastest one, because in a matter of 3 or 4 years we have made these strips available in the Netherlands for, I think now, 25 or 30 different drugs. And they are being used, and in the end I'm convinced we will sort of win this battle, simply because we are right and they are not. But in fact, the practical problems we had to solve, of which I thought they would be the hardest, like how should this strip look like and so on, they were in fact incredibly easy. All the available technologies existed and just had to be combined. And these strips I've made together with a pharmacist from the Rainbow Pharmacy, and basically we did it together. So it's basically 2 persons who worked out this concept. And because the pharmacist has a lot of contact with his clients, we also get feedback on things like, oh, people read something and we've written it down okay, but they understand something else, so we have to rephrase what we write down. Then you can make very big improvements, while if you start like asking from companies, you have to do this, they will start top down, and this takes many years or nothing is happening at all. That's why I don't expect that, that's why I think that you must not expect too much from the companies you want to solve this problem.
Yeah, I think you're right. And there was some naivety in my approach when I started to think about the petition. I did want to look to the pharmaceutical manufacturers for a solution because that's where the majority of the money is. And I feel they should better support the users of their products.
Well, the important thing, I think, is the fact that you started, because what you describe as naivety was precisely the same problem I had too. I expected something completely different, but because we had a very concrete idea and we just wanted to solve this problem, and initially it was a very small problem. We had the only goal, our first goal was to have one tapering strip only for paroxetine. And when we were solving this problem, then each time questions came up, and each time it turned out that these questions could be answered. And during what we were doing, the system we have now sort of emerged out of itself by working together between some persons. So with hindsight, the important thing for me was just to start. And I had precisely the same questions you have now. So you may think this naive or whatever, but it doesn't matter. The important thing is that you started it, that you get this attention, because that helps. That also helped me to come into contact with the right persons. Because I contacted many people, and in most cases, also from official instances, you get a very polite reply, but basically people are saying, I'm too busy, I'm not interested, we're already doing it, and nothing happens.
Yeah.
Then suddenly you meet some person or somebody calls you who said, hey, what you are doing makes sense, and we can do something together. That's why I came up, saw your initiative, I immediately reacted, like we can help each other.
Well, thank you, Peter. This interview being on the podcast will really help me raise awareness that tapering strips exist, and they've already helped well over 2,000 people to withdraw safely, and that people need to start asking their doctors for this help elsewhere in the world so the effort can be put in and progress towards a solution made.
Well, the awareness you can raise in the UK is very useful, because if in the UK people are interested, we will tell our ministry and say, and that we have done before already, like, we are not the only ones. In fact, we have had one question at one time from a pharmacist, from insurance company, why are these problems only in the Netherlands? And then we have to write back, these problems are not only in the Netherlands. You don't read what we have written down. And the strange thing is, things have come into, have gotten more attention here because the tapering strips now have been on Dutch television several times, and this creates more awareness. More patients are using them, they are experiencing that they work, and this helps. So by raising this attention, you can surely help, but you can also perhaps help yourself by making these strips available for people in the UK, which might actually be quite easy if it's possible to have them provided also in the UK, because they are available right now.
Well, you've certainly proved that the technical aspects of this are not especially challenging, and we just need the political will to get on with the work, don't we?
It should not be so difficult for patients that they have to find their own solutions. I mean, the problem has been created by the pharmaceutical companies who have made us use so many antidepressants, which has a good side, but they have always ignored the side effects and so on. And in fact, it's a shame that they were not obliged to help people to come off these drugs. They have made all these huge profits. They have made a lot of people use it. They've earned a lot of money about it, and now there are problems. Society can handle this. And this is weird. It should be a generic solution, and not a solution that should be only available for patients who are assertive enough or know enough. And that's what the tapering strips provide. It's really like buying shoes. You want a shoe that fits you, and not a shoe that is 5 sizes too large, because that's the only one that's available. But then we must give doctors the tools to do that. And currently, they are lacking those tools. They have guidelines which are not clear. And the doses the pharmacists currently deliver to you or to patients are not good enough to taper in a safe way. So that's what should be available for everybody, in my view.
It's obvious, isn't it, that we should be helping people who've decided themselves that they want to stop. At the moment, many feel stuck because doctors lack the advice and support and guidance that they need to help the patient.
And there are people who do several stop attempts, and each time they experience these problems, they're still not convinced. But if they are able to stop gradually in a safe way, and they are guided well, and after sometimes it turns out that they actually are better off using antidepressants, then perhaps they finally will be convinced to do that. And that is also a good outcome, because stopping each time while in fact you better take these drugs is also a bad thing. It's happening, I think, a lot currently. People basically hear all sorts of dramatic stories, but they have no tools to counter these problems in practice. So we leave patients in the dark very much, and doctors also, by the way.
Peter, thank you so much for your time today, and thank you for all of your hard work and effort to understand this problem and to do something about it. I'm hopeful that I can help you raise the profile of this solution, and we can get wider discussions happening on this whole issue.
No, but that's why initiatives such as yours and what we are doing, and there are other initiatives going on, are so important. And that's also why awareness in the press and with the general public is important, because what I've seen thus far is the only way to change things is to get this attention. Without that, we will not change much, unfortunately.
Well, I'm sure you'll agree it was really interesting to hear about Peter's work and the steps that he and the Cinderella Foundation have taken to provide practical support to those who want to stop taking psychiatric medications. If you visit my website, jfmore.co.uk, I will post links to Peter's work. Please go and have a look and help to raise awareness of this solution however you can. If you haven't already, please sign my petition, and if you feel especially motivated, write to your local politicians, explain the issue and advise them that a solution is available. If you want to, you can also provide links to Peter's work, to the petition and this podcast. Together it makes a compelling explanation of the issue, but it also makes clear that solutions are perfectly possible that would help patients and doctors too. Feedback. Thank you so much for getting in touch and sharing your feedback with me. Please keep your messages coming, as I love to hear from you. Finally, if you're struggling with withdrawal yourself and don't know where to turn, there are some excellent resources listed on my own website, jfmore.co.uk. Please go and have a look.
Please do not increase, decrease, or stop your psychoactive prescription medication without the advice and support of a medical or mental health professional.
Thank you so much for listening, and until next time, take care.
Thank you so much for listening to Let's Talk Withdrawal. Come back next week for more news and views. If you enjoyed this podcast, please leave a review and subscribe in iTunes.